This conference will now be recorded.
A very good evening to one and all present here. I, Afifa, on behalf of Biosetup Lifesciences, take the honor to welcome our founder, coordinator, Argidip Das sir, our resource person, Dr. Dattatreya Mukherjee, and all my dear participants. I welcome you all to the webinar on the topic tuberculosis, clinical and biological point of view. Biosetup Life Sciences is a hub for a scientific research and learning approved by ISO 9001:2015, certified and MSME Government of India registered organization having multidisciplinary team of faculty and research associates that provide support to aspiring students in life sciences. We have successfully organized many workshops, certification courses, career counseling, and competitive exam preparation like CSIR, IIT-JAM, GAT-B, IISc, and DBT. We are continuously working for the career upgradation of the students. Without further ado, let me introduce you briefly to today's resource person. Dr. Dattatreya Mukherjee has completed his MBBS from Jinan University, China, and has also passed NIH-funded certificate course in biomedical data management from Harvard Medical School. He has published several papers in international and national journals and has 5 patent publications. His main research interests are oncology, cardiology, neurology, and public health. We are delighted to welcome Dr. Dattatreya Mukherjee to be our guest speaker for today. Thus, without further delay, I request Sir to kindly proceed. Over to you, sir. Thank you.
So, 1 minute, just opening my camera. So, let me share my screen. Okay, so is my screen visible?
Yes, sir, it is visible.
Okay, so myself, Dr. Dattatreya Mukherjee, I'm a doctor. So my topic, today's topic is tuberculosis. So I will cover tuberculosis from the perspective of microbiology and from the perspective of medicine. So if you are from BSc or MSc background, then the 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 first part, that is microbiology, will be helpful to you. And if you are from MD backgrounds, then the clinics will also be helpful for you. So this is next slide. So is my screen visible now?
Yes, sir, it is visible.
Yes,
Okay.
sir.
So currently I am attached to the Raiganj Medical College and Hospital, and this is a new hospital. It's a new medical college actually, which has been made in 2018, and this is our building. That's the hospital building. So the next is tuberculosis. So what is tuberculosis? We everyone know that it's a disease. If you ask a normal class 10 or class 12 person, mostly they will tell that it's a disease of lung, but it's not a disease of lung only. There is another word called miliary tuberculosis or extrapulmonary tuberculosis. So whenever you are diagnosing in tuberculosis, you have, and when you are writing a case, then you have to mention it is pulmonary tuberculosis or extrapulmonary tuberculosis. For pulmonary tuberculosis, we usually write it PTB, P for pulmonary, and for extrapulmonary tuberculosis, we write it as a extra PTB, means extra pulmonary tuberculosis. So this is a microbiology background that tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. It's we I think from class 10 we know this thing. So in the Wikipedia, I took this from Wikipedia. There is a domain. It's a bacteria. If you know, tuberculosis is not a fungus, not a virus. It's a bacteria. Okay. This phylum is Actinomycetota. Class is Actinomycetia, and order
Sir, sorry to interrupt, but you are not audible.
This conference will
Now
now
you,
be recorded.
I am audible or not?
Yes, sir, you are audible.
So
So
Mycobacterium
Mycobacterium
tuberculosis is
tuberculosis is
also called
also called
MTB.
MTB.
Sir, your voice is echoing.
So Mycobacterium tuberculosis, it's also called MTB. So it's a bacteria, as I told some few minutes ago. So the next thing is it is not a gram positive or gram negative type bacteria. It's a mucolytic type of bacteria. Okay. It's a mucolytic type of bacteria, and so there is a work present on the bacteria that is called mucolic acid. This word is very important. So if you that is a tuberculosis is gram, if someone asks I'm positive.
Hello.
Hello,
Can anyone
can
confirm?
anyone confirm?
Hello.
Hello,
This conference
mucolic
will
acid.
now be recorded.
This is called mucolic acid. Mucolic acid. So tuberculosis is not a gram positive or gram negative type of bacteria. It's called a special strain as a FB strain type bacteria. So to identify tuberculosis, you have to run FB staining, not gram positive or gram negative type of staining. That's an acid first stain, such as gel Nelson. If you studied MBBS in pathology, this is a very common stain. You will study that the gel Nelson staining or fluorescent stain such as Oramin. This is not so much used, but gel Nelson staining is commonly used. That's called AFB staining. That's why tuberculosis is also called acid fast bacilli. Okay. So the next thing is next thing is the aerobic or anaerobic. This is another MCQ. Tuberculosis is an aerobic type of bacteria. That means to survive it needs oxygen. That's why PTB is most common. The pulmonary TB is the most common part because lungs gain the maximum amount of oxygen. Okay, so but apart from lung, any parts of the body can have tuberculosis. That's called miliary tuberculosis or extra pulmonary tuberculosis. Okay, apart from the test are you can tuberculin test or Mantox test. We will discuss this test later. Acid fast chain culture and polymerase chain reaction. The first genome sequencing was done in 1998 of tuberculosis. Any question in this slide? Am I audible?
Yes,
Hello,
sir, you're audible.
audible. So any question in this slide? remember one thing from this slide, take home message, that tuberculosis is not a gram positive or gram negative type of bacteria. It's a special type of bacteria which is AFB type, that is acid fast bacilli. That's why to identify tuberculosis you need to run acid fast strain, that is a gel Nelson strain. Okay, so next, pathophysiology, how tuberculosis actually spread. Tuberculosis actually spread through the sneezing or sneezing, and the aerosol type of spreading, that when you will sneeze, a tuberculosis patient sneeze in front of you, the bacteria will be present in the aerosol, and when you will inhale that air, it will actually enter in your lung. What happens when it will enter in your lung? um, when you will enter in your lung, then first it will that is the name is lysosome. First it will it will interact with the lysosome. First lysosome makes want to make some defense, but unfortunately many times lysosome can't defend it. So if it can defend, there is a complex usually prepared, there is a tuberculosis lysosomal complex, and lysosome usually want to throw the tuberculosis out of the lung tissue. But if lysosome fails, then then the cell mediated immunity actually happened in case of tuberculosis. That's why you will not find any type of, what I can say, that's the antibody in case of tuberculosis. Okay, so the thing is that that time actually macrophage usually work. Macrophage makes a complex with tuberculosis, that's called Ghon complex, and Ghon complex usually spread through the hilar lymph node of the lung. So this is actually the pathophysiology of the lung. Sorry, tuberculosis. That you will get a word called Ghon complex. Actually, Ghon complex is the necrotizing tuberculous tissue surrounded by the macrophages, and involvement of one higher, also not one, as the hilar lymph nodes. That's called the Ghon complex. Now, two type of things can happen if you are if you are mm, uh, if you are immunocompressed patient, then maybe why immunocompressed, maybe the patient has HIV, maybe the patient has some carcinoma, or the patient can have any organ transplant. Then this Ghon complex, this actually stays in the latent phase, and then when the patient goes to immunocompression, then the tuberculosis bacteria usually get stronger, and it usually spread and shows symptom. Okay, so we doctors usually have, every doctors usually have with this tuberculosis the things, because we treat tuberculosis frequently, and because we don't get the symptoms because of immunocompression, that's why we usually been told by our seniors and professors, always take your meal before coming to the ward, because we usually treat tuberculosis each and every day, and if we have lack of immunity, then tuberculosis will show symptom, otherwise it will stay in the latent phase, so it will not show any symptom. This is a Ghon complex I have told just now. The Ghon complex, as it actually, this is the, as a written as a background, is the pulmonary lesion. There's a Ghon lesion. Ghon lesion usually contain one necrotizing tuberculous tissue, and surrounded by the macrophages. And when hilar lymph nodes or ipsilateral hilar lymph nodes are added, are involved, then it's called the Ghon complex. That's why when you will see a chest X-ray of a tuberculous patient, then you will see the patchy appearance. The patchy appearance is due to that fibrosis which happens due to this Ghon complex. Okay. So next is the pathophysiology. As I told that first the bacteria entered into the lung. Then first the defense given by the lysosome. If lysosome is fails, then cell mediated immunity starts. In the cell mediated immunity, you will find Ghon complex, because the tuberculous tissue is surrounded by the macrophages, and then if your immunity is good, then the tuberculosis will stay in the latent phase. It will not show any symptom. But if your immunity is not good, then it will show symptoms. For pulmonary tuberculosis, the most common symptom is cough more than 3 weeks, and there will be there may or may not hemoptysis. That means the sputum, blood in the sputum. Okay, so these are the common symptoms we get. You may get respiratory distress, or you may not get respiratory distress. And if in the miliary tuberculosis, you will get TB in that area. For that, you need to test. For lung also, you need to test. We will discuss the test sometimes after. So these are the these are the what I can say, the Ghon complex, the pathophysiology. In the pathophysiology, you have to remember the Ghon complex if you are a pathology student. So and if you're a microbiology student, then you can remember the pathophysiology part. In this pathophysiology, there are a couple of more cell mediated immunity I will be informed. That is the interferons, gamma, and other interferons. So this is a part which you need to be memorized. Now test, there is two tests. Mantox test. There are not two tests, a couple of type of tests. First is Mantox test. This
Sir, your PPT is not visible.
yes, I've seen.
It is visible now.
Okay. So the so TB skin test for TB. Sorry, TB, for TB skin test, it's also called Mantox test, or it's also called tuberculin test. It's a most non-specific test, because in respect of India, we all have TB in the latent phase, because India is a hub of tuberculosis. So that's why if this test has been done in any individual in as per India, you will get it positive. So what we do in the Mantox test, we usually enter PPD in 0.1 ml in the lower part of the arm. Then we observe it for 48 to 72 hours, and then we measure it. See, there it's there in the scale they are measuring it. If it's less than 50, if it's more than 15 mm, or 15 or 15 mm, more means if it is 15 mm or more than 15 mm, then we think it's Mantox positive. What's the Mantox means of Mantox positive? It signifies that the patient might have tuberculosis. But as I told, it's a most non-specific type of test, because in India, where tuberculosis is so endemic, that you will get it positive. If someone tests in my body, it will surely come as positive, because we treat tuberculosis patient, and all the time in the ward we will not get to know that he has tuberculosis or not, because a patient is coming in front of you, he no mask, nothing. So maybe after one day you came to know, okay, the patient was tuberculosis, or the patient has tuberculosis. So these kind of things. Next is the TB blood test. What is the TB blood test? IGRA. What is IGRA? Interferon gamma assay. And there is another called T state. TB spot test, so T state. But unfortunately, in India, in my clinical setup or clinical experience, I haven't seen this test to be done. So this is for book, it's okay. For practical life, I haven't seen this test to be done. So BCG. So BCG, you all know that you all have a mark in your arm. Actually, it's in your upper part of the arm. So it's BCG. So BCG is we usually give it to IM, that is the intradermal. Okay, it's given on the deltoid muscle. If you see your deltoid muscle, mostly in the left hand you will find a mark. Why the mark is there? Because when you born, you got this vaccine. So it's called BCG. BCG, the full name, it's a question of viva, bacille, calmette, guerin. Okay, so 3 vaccine you get after the birth in day 0. One is BCG, another is hepatitis B, another another T, another is vitamin K. 3 things you get when you at day 0, means as soon as you born, you will get these 3 vaccine. So this is called BCG vaccine. Now, several you will also read several controversial reading that how many years BCG can give you protection. The Melinda Gates and Foundation, you know, the wife of Bill Gates, they are doing some campaign and research to see that how many years these vaccines can be effective, and if it's needed to give to jab this vaccine again or not. So these kind of researches are going on. But still now, as per WHO schedule and as per Indian vaccination schedule, BCG is given at day 0 only. Again, my PPT gone. Am I audible actually?
Yes, sir, you are audible.
Yes, sir. Yes, sir, you are.
So the what we use in day-to-day clinical setup, that is a FB stain. There is acid fast bacilli stain, as I told you, Gel Nelson. So what we write for when we want to test for TB, AFB. So sputum for AFB, or amniotic abdominal fluid, ascitic fluid for AFB, or pleural fluid for AFB. That means we are sending the sample for the AFB staining. Then another is CB0. CB0 is more what I can say, the specific than AFB. If a patient got come as negative in AFB but positive in CB0, we will tell that the patient is TB positive. And another is more specialized, that gene expert. If the patient is negative for FB, negative for CB0, but positive for gene expert, then also we will tell that the patient has TB. So these 3 usually we give for in the patients in clinical setup. Mantox is very non-specific, so I don't. For in your clinical setup, it's very less significant to be done. It don't have that value. IGRA and T-Spot, I don't think it's available in the government setup. I have no idea in the private setup, but in government setup, it's not available. And in USA, there it's available, but in India, in government setup, it's not available. So we diagnose TB through AFP and CBNAT. More extensively, Gene expert. We usually we no need to be done. No need to do. AFB CBNAT is quite good. You will get the result through AFB or CBNAT. Let's discuss some case. So first is a 21. Yeah, these I have actually I have treated many TB patients, actually around 100. In that 100 TB patient, I have highlighted the 4 TB cases for today's lecture. One is first case is a 21 years old female presented with hemoptysis, that is the sputum in the cuff. Blood in the sputum during the cuff. The cuff is productive. Mostly in TB cases in India, you will get productive sputum. That is the productive cuff. That is the cuff has sputum. Okay, but it's not necessary. The sputum, it can be dry cough also, but in India, mostly in my experience, I have got productive cough and hemoptysis, that is the blood in the sputum. Respiratory distress, so we haven't given oxygen, the blood in the, she has no respiratory distress, gave any oxygen to the patient. She has recent history of weight loss, and her mother complained that she don't eat food. So she in another type she is malnourished. Okay, and his neighbor, sorry, it will be not his, her neighbor had TB. Okay, so this is a very important fun when we are taking the history. Hemoptysis, okay, weight loss, and neighbor had TB. So automatically we will think there might be a chance of TB. Yes, we sent the sputum for AFB and CBNAT, and it came as positive. The patient is getting the TB medicines and anti-tubercular drug, and in the follow-up, the patient is doing good. Another, a 43 years old male admitted in the ward with hemoptysis and respiratory distress. Again, my gone. Just I'm sharing it again. Okay, so the next case is a 43 years old male admitted in the ward with hemoptysis. Uh, he had respiratory distress. He had history of TB 20 years ago, and at the age of 23, he had TB. He is a non-smoker. His X-ray shows patchy appearance. Obvious, when a patient had TB, her X-ray will show patchy appearance because TB cause fibrosis in the lung, and the CT shows cavity-like appearance. That might be the Ghon's complex. So in this case, when we have again done the sputum analysis with AFP and CBNAT, it came as positive. Again, this patient got the TB anti-tubercular drugs and doing good. The most dangerous one, TB is not dangerous, but MDR TB is very dangerous. The mortality rate is very high. MDR TB is multi-drug resistant TB, means whatever drug is available for to treat the TB, all the drugs are resistant, means TB is resistant, that mycobacterium tuberculosis is resistant to all the drugs. Recently in Kolkata, one medical student died in MDR TB because we are very vulnerable to get all those. If we get in by any chance we are if we get to immunocompromised, then we will have this TB. MDR TB is very nasty, very nasty. It's not, I think it's November or December, one medical student from Kolkata has died because of MDR TB. So wow, a 35 years old female MDR TB was admitted in the ward. So MDR TB means it's multi-drug resistant. No drug will work on this TB. The prognosis is very poor because no drugs is working. So this patient actually we are treated this patient, but suddenly I was on my duty. Suddenly the patient came.
Sir, you are not audible.
And the patient I 1 minute, just give me a minute.
N-
The
Now you
patient
are audible,
died
sir.
within the 30 minutes of the within the 30 minutes of the admission. Okay, so I declared the death within the 30 minutes. After the 30 minutes of the admission, the patient passed away. So MDR TB is very nasty. So TB can be treatable, but MDR TB it's very tough to treat because we don't know which drug will work. And in that patient in this patient with 35 years old female, all the drugs were resistive. So you can see, you can imagine the situation that much mutation happens. Another is that this is a case of extra pulmonary tuberculosis. A patient was admitted, a 60 years old patient was admitted with ascites. I had done the ascitic tapping, that is the pericentesis, and we sent the fluid as ascitic fluid to the lab for AFB and seminar, and it came as AFB positive. That means the patient had TB in the gut. Many times what usually happen in this area, the patient had PTP, but it is in the latent state, but the patient has swallowed the sputum, and the sputum has gone into the GI tract, and then it caused the what I can say, it caused the tuberculosis. It's a case of abdominal tuberculosis. Today only we got a case tuberculosis in the testes. It can also happen tuberculosis in the testes. So it's in our area, in this belt, tuberculosis is very common. If so it's not been eradicated yet. Tuberculosis is still very common disease. Again my screen gone. Is my screen visible?
No, sir.
Hello?
No, sir, it is not visible.
Hello?
Hello.
Your screen is not visible.
Hello? Just wait a minute. I'm rejoining. Case
This
of
conference will now be
GITB as the
recorded.
extrapulmonary tuberculosis. Now let's talk about the drugs. HRZD is a combination of drugs we usually give for tuberculosis. That's what are the four drugs? Isoniazid, rifampicin, pyrazinamide, and ethambutol. HRZD. H for isoniazid, R for rifampicin, Z for pyrazinamide, and E for ethambutol. Uh, TB drugs is usually gone for 6 months to 9 months. It's a long treatment. Yeah, there is actually TB clinic where you will get these drugs free of cost from government of India, and you have to come. You will have a card actually, and you have to come regularly for the follow up and the testing. When the CB naught will be fully negative, then you are TB negative, or you can say you are out of TB. So pyrazinamide gets so what is the mechanism of action of mechanism of action MOA of these drugs? Pyrazinamide actually gets activated to pyrazinoic acid in the bacilli, where it interferes with the fatty acid synthesis phase 1. So this is a tuberculosis bacteria. So where the drugs can work? React first, it can work in the reactive species. Which drug usually work? That is the pretomanide. This drug usually work in the reactive species. DNA guidance, which drugs usually work in DNA guidance inhibit as a DNA guidance inhibitor, as a levofloxacin, moxifloxacin. This group of drugs, which drug usually for RNA polymerase inhibitor, that is the rifampicin, rifabutin, this kind of drugs. Which inhibit the ribosomal activity, that is a streptomycin, okay, amikacin, kanamycin, lineazoid. So this kind of drug who usually inhibit the ATP synthesis, betaquilin, and who usually break the cell wall and destroy the cell wall, that is the isoniazid, ethambutol. Okay, so these are the drugs use mechanism of actions. These are the drugs usually given to the TB patient. So this is the whole lecture on tuberculosis. Next is this is like the family program that we usually 1 minute. These are family programs we usually this is our PSM department or community medicine department. We went to a village for the family programs to see the health status of the families. This is the part of the rural project of India, government of India. We have to go to the villages and we have to check the health condition of the villagers. So this is okay. This is my day-to-day life. We usually do these things as a doctor, and thank you. So up to this is my lecture. I am open for questions.
Thank you so much, sir. We will go ahead and take some time for questions now. So any students having any questions can type questions into the chat box.
Okay,
We will take a
I'm
minute or
open
two.
for questions now.
Yes, yes, sir. Students having any questions, please type them into the chat box. Do not open your mic. Sir, looks like we have a one question.
First question is that is MDR TB is curable completely? No, MDR TB is mostly not curable. That the drugs. The thing is that the drugs are very less. Most of the cases, patient couldn't survive. Am I audible?
Yes, sir, you are audible.
Okay. So the next question is: we totally irrigated TB in India? Yes or not? Absolutely not. If we could, because we in future we can, but still now we are not because of the weather. In the weather is the moist weather of India, the humid weather. So no, India is TB is still there in a large amount in India. So it's absolutely not eradicated till now. Do tuberculosis spread like cancer? I mean, tuberculosis have metastasis. Tuberculosis, as there is no connection between tuberculosis and metastasis. Cancer is completely different. Tuberculosis is completely different. Tuberculosis is a communicable disease. What are the test cost? In it's free of cost in the government setup. I have no idea in private setup, but in government setup the tests are free of cost. Sir, if the patient has tuberculosis and lung cancer in first stage, what will be the line of therapy? First, we have to treat the tuberculosis, followed by the lung cancer. The prognosis will be poor as usual. As I told that because the cancer is immunocompromised state, so so the tuberculosis will show a very will show a very significant amount of symptoms. So in this case, we simultaneously actually we should do the both the treatment. But if the patient can't take the treatment simultaneously, then we should give the chemotherapy. Then we should continue with the tuberculosis um, the regimen. So I think it should go simultaneously. Symptoms of MDR TB. Symptoms of MDR TB just exactly like TB. When you will test, it will come negative. And MDR TB is the multi-drug resistance, so the drugs it will be resistant. Okay, so and if the symptoms of MDR TB, that's a see the MDR TB is also a TB, but it's what I told the drugs, it's resistance to those drugs, so the prognosis will be very poor. The symptoms will be like same. In the end stage, that the MDR TB you will get severe respiratory disease that I got. That the patient was came as a gasping severe respiratory disease. SpO2 was 30-35. I'm a Malik. Thank you for thank you, Ramesh. But why? Why means I couldn't understand why. Of why of what? Can MDTB be treated bacteriophage as this TB bacteria are multi-drug resistant? See, there are a couple of researches going on to treat the MDR TB, but still now the prognosis is poor. Um, Bacteriophage, it's all are like theoretically everything possible, but practically the scenario is completely different. So still now MDR TB is still unconfirmed, but I can say as my clinical experience, what is the duration of MDR TB regimen or RRTB? See, TB regimen gone for 6 months to 9 months usually. It all depends on the test should be come as negative. Is there any treatable way available that can prevent what is the main role of Gone complex? Gone complex, the main role is the immunity. The macrophage basically wants to eradicate the TB. That's why macrophage gets around the tuberculous bacteria gets surrounded by macrophages, and it caused necrosis in that area. That's why in the it's a necrotizing granuloma, you can say that's called a granuloma. Necrotizing granuloma is formed in the case of TB, and the whole complex with hilar lymph node, ipsilateral hilar lymph node, that's called Gone complex. So uh, that the other question critical is MDR TB. What is the main role of Gone complex? Answer: TB is also a FS AFS, yes, yes, TB. No, TB can when it is AFB negative, then it's not a communicable state. Might be can present in your body as a latent state. In the latent state, it's not it can't infect others. But when the patient will again go to immunocompromised state, then it will latent state will be activated. Then again the patient will be as we can spread the disease. Usually patients upset stomach, nausea, vomiting, diarrhea well after that. So in few months when the complication get resolved, patient do stop ATT or interval. Yes, that's why I told that the government has set up DIFA for government set up the TB clinic. Special medical officers are for TB. Government has appointed. So the counseling is important. But yes, in this big country, lots of population, it's not possible to counsel each and everyone, because we can counsel the patient, but after that also TB after that also people usual don't take drugs and all. That's why it's tough to eradicate TB from India. It's a challenge, but yeah, counseling is a very important part, because it's 6 to 9 months of treatment is not a matter of joke. But we don't have any other options. So yes, uh, that's why it's tough to eradicate TB from India. How to maintain immunity, enhanced immunity? As I told, BCG, what you have got in your childhood is one of the immunity. Again, currently researches are going on about the efficacy of BCG in the later part of life. And always keep healthy meals, like eat healthy meals. If your immunity is good, you will be away from tuberculosis. Can um, can 1 minute. So excuse me, my professor is calling me, so I please excuse me for 5 minutes.
This conference will
Sorry for
now
this.
be recorded.
So another question is that how to can TB spread after AFB test negative? No, it can't be spread out when the AFB strain is negative. Since you have stated that TB skin is of no use in India, TB blood test is in the hospital by the government. What are the methods? As I told, AFB and CBNAT is used mostly in the clinical setup. Gene expert also can be used in the clinical setup. In Indian government setup, IGRA I have not seen, and Mantox is not that much specific, so it's no use of doing it. You for prevent for screening purpose you can do it, but for if the patient is coming to hospital or something, no, Mantox has no use. How does it spread to organ than lungs, as you mentioned? it can spread. The bacteria can spread through organ to, with the blood circulation, like in the GI. It can go through the sputum. The patient has ingested the sputum, and then the tuberculosis rich bacteria sputum gone into the TB, and it called GI type of uh, GI tuberculosis. Apart from this, testis is through blood circulation. It can go. So there are evidence of extrapulmonary tuberculosis. Can TB survivor live normal life after treatment? Yes. When you provide certificate, the organizer will tell you. Any more questions? No. Is it reversible? Color of the skin during the treatment? Color is not connected with the TB. Is why skin color change to man in TB treatment? Okay, skin color change in TB treatment because ethambutol. Sorry, um, that's the rifampicin. Rifampicin cause red color urine, that red man syndromes because of rifampicin. Rifampicin cause this thing. I can show you the rifampicin, red man syndrome. Rifampicin cause red man syndrome. That's a side effect of the drug. It's a question usually comes in MBBS level. The red man syndrome. Uh, Due to that drug, it usually happen. You will find a red color urine also because of this. MDR. What is the permanent side effect of MDR TB treatment? It's depends on the drugs. Okay, every drug has side effect. Like I told that ethambutol, rifampicin and Redman syndrome. More or less, if every drug has side effect, but in medicine we usually go for profit loss phenomenon. If profit is more, loss is less, then we'll go proceed to the treatment. So if tuberculosis is cured completely, what are the chances to TB back? I again told that TB mostly present in the latent state in your body. When the body will get the immunocompromised state, then again the TB will come. Means again it will show the symptom. So after the TB treatment, yes, if the patient in maybe like I discussed one case after 20 years, he or she again got that TB. There are two chances can happen. One, that patient has get the newly fresh tubercular bacteria. This can also happen, or the tuberculosis was in the latent phase, and again after the time it's again like the bacteria again shows symptom due to the immunocompressive state. Okay, so I am ending my lecture today. I have to attend another conference, with a physical conference, so I have to go there. So thank you everyone.
Thank you so
Over to
much, sir.
all.
Yeah, thank you so much, sir. I would like to use this opportunity to thank our today's resource person, Dr. Dattatreya Mukherjee. Thank you so much, sir, for your time and all the knowledge you have shared today with us. It was truly delightful learning from you. Hope everyone felt the same. Also, thank you for accepting our invitation. Looking forward to collaborating with you on many more events in the future too. We are very grateful to have you here with us today. Great. Thank you, everyone. We appreciate you being here. For the students, filling out the feedback form is mandatory for your attendance. I will be sharing the feedback link in the chat. Please wait.